This student interest video presentation was brought to you by the AAFP and the AAFP Foundation. For these families, hunger and illness are their daily norm. Most survive on an income of less than $2 a day. They live in unsanitary conditions. They have little or no access to health care. The resident who took this picture encountered this family walking near a garbage dump in Belize, Central America. The little girl took the physician's hand and anxiously motioned towards her family. They needed help. We know there are families all over the world that need family physicians to care for them.
There are people that are in such dire needs, and it made me realize it doesn't really matter whether you live in this country or live in another country. We're all human beings, and we all deserve the same right to health care and to basic human conditions, and that we need to be servicing people wherever they live and serving those people wherever they live, not just in the United States.
There are striking inequities in the healthcare systems around the world. Did you know that the difference in life expectancy between the richest and poorest countries now exceeds 40 years? Did you know that out of the 136 million women who will give birth this year, 58 million will receive no medical assistance during childbirth or after, endangering their lives and their children?
In many parts of the developing world, there has been little change in the way healthcare is practiced from 40 years ago to now. The majority of kids who die are dying from simple diseases, still diarrhea, malnutrition. They are not dying from HIV/AIDS to the extent of these other simple diseases that we as family physicians can do something about.
I really am a strong advocate that a well-trained, residency-educated family practice doctor is the best tool to meet the needs of the developing world. I mean, there are two good reasons for family docs to become involved in international health. One, the world needs it. Those who've gone overseas are confronted with this tremendous need. We know that 2.6 billion people live on less than $2 a day. That a child raised in the developing country will, with rare exception, live to adulthood, but that same child in a developing country stands about a 65% chance of making it to their 5th birthday. I mean, the need is great. And the second reason why I think we need to be involved is we need to serve. I think family practice selects out a med student or a resident that is really high on the compassion index. They already come into family medicine with a desire to help people, a desire to serve. And I think we as family practice, really need to lead American physicians in this charge to serve, to move from just success to significance.
Meeting people's basic health needs requires addressing the underlying social, economic, and political causes of poor health.
Modern societies devote a very large share of their wealth, effort, and attention to try and maintain or improve the health of individuals in a population. These massive efforts are primarily channeled through the healthcare systems, presumably reflecting the belief that the receipt of appropriate health care is the most important determinant of health. Receiving appropriate health care is the most important determinant. There was a recent article in the New England Journal that actually blew that out of the water, I think, where they actually said, if you had to say what % of healthcare outcomes are impacted by the healthcare system, what % do you think it would be as we go through the determinants? And it's actually around 20%. There's about 80% that has much more impact than just the healthcare system.
Improving living conditions is crucial to sustaining a healthy community and healthy individuals. We can do more for most populations by improving nutrition, sanitation, housing, education, and income. The Director General of the World Health Organization recently observed, "We see a mother suffering complications of labor without access to qualified support, a child missing out on essential vaccinations, an inner-city slum dweller living in squalor." These and many other everyday realities of life personify the unacceptable and avoidable shortfalls in the performance of our health systems. Now more than ever, we need primary care. The specialty of family medicine plays a unique role in preparing physicians to practice around the world. There are global health training models that meet the needs and interests of all types of medical students looking to practice full-time or part-time on the world stage. For example, the shoulder-to-shoulder model, started by the University of Cincinnati in 1993, is a network of partnerships between 8 family medicine training programs and communities in rural Honduras and other resource-poor countries. The program combines an educational mission with a long-term community development project.
I really believe that family medicine is the specialty of choice for global health, and it's because of family medicine's emphasis on continuity of care and emphasis on the care of patients within the context of family and community. And that's what we need to be doing in these communities. We need to be looking at not just the health of an individual problem that's presented to us, but what are the determinants of health? What are the things that underlie the diarrhea in the 2-year-old, the cough in the whole family, the poor nutrition? And if we're not doing something to address those underlying causes, we're not really going to have any kind of lasting impact. Family medicine emphasizes a long-term relationship, and we're mirroring that with the shoulder-to-shoulder model, having a long-term relationship with a residency program with the community in Honduras, and I really think that's the way to go.
We grew a program in the early 90s that has since incorporated about 5 to 6 different sites in our rural Honduran site, as well as partners in Tanzania, Ecuador, and other parts of Honduras, and I believe now has 8 different departments of family medicine working together to try to bring a longitudinal partnership model to global health.
The shoulder-to-shoulder model is looking at determinants of health, and what that means is instead of focusing on providing clinical care, looking at the things that determine whether a community and a family is healthy or not. And one of the things in Honduras is people spend an inordinate amount of time focusing on just getting firewood, just getting water. And so if we can help people decrease the amount of time they spend getting firewood, getting water that's clean, we think that's going to have a lot bigger impact on their health than just providing basic clinical care. So we're working on things like improved cook stoves, slow sand filters, improved agriculture, improving the resources that the local schools have so that children can learn better. So we approach the community by saying, what do you need? What are your needs as a community? And then are we really a good fit for that community? So we talked to several communities before we decided on San Jose, and we were just really impressed by the cooperation that the San Jose community had showed in building a road down to their village, and just what they needed was what we thought that we could provide.